Well, hello everyone, and welcome to this Partnership Centre in Health System Sustainability webinar. And today we're talking about perspectives on social prescribing. We'll just wait a little while to allow people to join, and then we'll get going. So if you're just joining us, I hope you're in the right place. We're talking about social prescribing today. We're just waiting for a couple of seconds just to allow our colleagues to join us. And we'll get going probably in about 1 minute or so. All right, we might get started. A warm welcome, everyone. Thank you for joining us today. My name is Yvonne Zurynski. I'm the Associate Professor of Health Systems Sustainability at the NHMRC Partnership Centre for Health Systems Sustainability at the Australian Institute of Health Innovation at Macquarie University. And we're talking about something very exciting today, looking at different perspectives on social prescribing. This is one of our webinar series. And thank you very much for joining us, and I hope you'll enjoy the session today. We have some wonderful speakers, and then we have about half an hour allocated for discussion, which is always the most important and exciting thing, exciting part of the presentation. I would encourage everyone to please use the Q&A function on your Zoom to post any questions. We want this to be interactive, so please don't be shy. Just use that function as much as you can throughout the presentations, and we'll endeavour to answer your questions as a panel. There may be some questions that we don't get to, and that's okay. We'll take those on notice and answer those later. We are recording this webinar, so if you know of any colleagues who might be interested but were not able to make it today, this will be available on the PCHSS website within about a week. And so please spread the word if other people want to view it, or you want to view it again. By all means, use that opportunity. All right, so I have the honour of presenting, acknowledging country today. So we acknowledge the traditional custodians of the land on which Macquarie University is situated, the Wallumattagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the dream time. We pay our respects to elders past, present and future. And of course, all of us are on different lands. I would like to acknowledge the land that I am on today, the Wongal land of the Eora Nation, and all the other lands that the presenters and participants are joining from. So a little bit about the PCHSS. Just briefly, the Partnership Centre is a large NHMRC funded collaboration. We were funded for just over $10 million. It's a 5-year grant. It's a very large endeavour. There are 17 lead investigators and 20 expert advisors, and over 40 system implementation partners from around Australia. So being national, as you can see, we have lots of people located around the country, and the investigators and system partners span all of Australia, including different sectors, academia, public and private health providers and hospitals, health insurance, government, not-for-profit healthcare, and most importantly, consumer advocacy organisations. We're very closely linked with the Consumers Health Forum of Australia, for instance, among others. Okay, our vision is really to produce research that contributes to the development of a resilient healthcare system, one that is affordable, cost-effective, and delivers improved health outcomes for all of Australians. So we don't just want to do research for the sake of doing research. We really want to do translational research that makes change in the system. Okay, and our purpose is to generate and disseminate ideas and evidence to improve the performance of the health system so that it delivers care efficiently and effectively over the long term. And we seek to maximise health system improvement in the real world, as I said. And that we can only do that by bringing people together and people who provide, plan and use health services. Okay, I just need to find my cursor, which has disappeared. Here we go. All right. So we have three main streams in the PCHSS: analytics, technology and shared data. We're really keen on reducing waste and low value care in the system. And of course, we all want to do, we want better value for the health dollar, which is they're becoming much more scarce, of course, as we face increasing challenges, not least the recent pandemic. The Observatory on Health System Sustainability is sort of an overarching coordinating unit that does its own research as well as coordinating the very large centre. So today, I'll just briefly present and introduce our guest panel. We're really pleased to have such fantastic speakers today. Firstly, Mr. James Sanderson, who's the Director of Personalised Care from NHS England. He will be joining us virtually. He's done a pre-recorded presentation for us, which is fantastic. It's very early in London at the moment, so we're very pleased to have his contribution to this webinar. We also have Professor Mark Morgan. He's Professor of General Practice at Bond University and Chair of the RACGP Expert Committee on Quality Care. We have Carolyn Dew, who is an artist and one of the developers of the Cultural Pharmacy Social Prescribing Program. I've seen Carolyn speak before and I think you're in for a treat there. And we have Helen Longhurst, who is a health consumer advocate, and she has personal experience of accessing social prescribing for her own needs. So a really great lineup, and I'll let the speakers introduce themselves as they begin their presentations in more detail. But I would like to start by just giving a bit of background around what social prescribing actually is, and to give you a little bit of a taste of some of the work that we've been doing over the last couple of years on social prescribing. So it's really a mechanism of linking patients or consumers or people with non-medical sources of support within the community. The types of people that tend to be referred to social prescribing programs include older individuals who might be experiencing isolation or loneliness, other people who are socially isolated or lonely and disconnected with community. Young mums, so in the first 1,000 days of life, mums often struggle with connection with community and mental health problems as well. And of course, people with mental health conditions have been shown to benefit from social prescribing, as well as people with chronic health conditions. This isn't to say that that's comprehensive and that's it. I think most of us would probably benefit from social prescribing now, particularly if you live in Sydney or Melbourne and you've been in lockdown for 3 months. We're certainly all missing that social connectedness and being with people. So usually the way it works is that GPs or healthcare professionals refer patients or consumers to programs, activities. They give them special information, or they refer them to community services or social care services. Social prescribing is a term that's used a lot in the UK, but in Australia, I often find that when I'm speaking with people, they have no idea what social prescribing is. And when we did some work around, looking at the literature and what's been published around social prescribing, we found at least 75 different terms that are used to describe this practice. And, other terms include things like community prescribing, social connectedness, life scripts, community referral, green prescriptions. And the destinations of these prescriptions are also very varied. So you might have arts on prescription, or you might join a book club for bibliotherapy. You might be prescribed an educational course that might be of use. Exercise referrals and exercise on prescriptions. And I think that is very, very common. Certainly that's what we found in one of the surveys that was conducted by the RACGP and Consumers Health Forum. Healthy living initiatives, things like smoking cessation, nutrition, etc. And activities in nature, also known as green prescriptions. So spending time in nature is actually really beneficial to people. The way that this happens also varies. So the literature talks about signposting, and that's simply telling someone to go and access a program or, a website or a resource without necessarily supporting them on their way. Then there are supported referrals, and that usually involves a navigator of some kind, a link worker. That's the person that spends a bit of time with the patient or the consumer to figure out exactly what their needs are and what program might be of most help for them. And there's also self-referrals. So consumers or patients can make the first move and actually take it upon themselves to link themselves up with community services that they feel will be of benefit. And you'll hear a little bit about that from Helen and her experience. So usually this link navigator or link worker sits in between the health professional or GP and the community service. The link worker or navigator, according to the literature, is usually a member of a community group, someone who is within the health system but knows resources in the community. They may be a member of a commissioning trust, and that's a very English UK term. So they have trusts over there, or they may be a volunteer in a charity, and the charity might be running, community activities, etc. But that doesn't always happen. There isn't always a link worker or a navigator. And there are also direct referrals. So GPs and physios and other health professionals do refer people directly to community programs. Some of the hallmarks that we've identified, and there isn't a huge amount of literature on this, but some of the hallmarks that we identified for successful social prescribing include individualized person-centered needs need to be taken into account. So the prescription needs to be individual and relevant to that person's needs. You also need programs available, accessible and culturally appropriate, and also of low cost or free, so that people can actually engage with them. Often the prescription relies on building trust and relationships. And if you have a link worker involved, then that person really needs to have the trust of the health professional as well as the person who's receiving the prescription. Co-designing solutions is a big part of this. So figuring out together, particularly with the patient or the consumer, what is needed, what kinds of approaches would work for that person, and also flexibility and place-based approaches. All right, so much of the literature is saying that it needs to be more than just signposting. And so that role of the navigator or coordinator or whatever they are called, and they have been called many, many different terms, that seems to be a key position to help people engage with social prescribing. In Australia, we undertook several surveys. So the RACGP, the Consumers Health Forum of Australia, and the Organisation for Allied Health Professions undertook some surveys. And some of the things that we found were really interesting. So consumers in general were really supportive of social prescribing. So they felt that community programs can help manage health and well-being. 70% of GPs, and Mark was involved in this survey, said that they believed referring patients to community activities, groups or services helps to improve health outcomes. But most said that they didn't really have links with such services. And then when we asked consumers about, their sort of primary providers, whether primary healthcare providers, whether they refer them to such programs, they said rarely or never. So there's a bit of a mismatch here. 70% of GPs are saying, yes, we do this, and consumers are saying, no, we don't. A clue might be that the GPs were recruited from those who sit on committees for the RACGP, and so they may have been more aware of these programs and actually doing and participating in referring patients to these programs. We've also done some work around, identifying enablers and barriers to referral. We know that social prescribing is not done ubiquitously across primary care. And some of the enablers that we identified in the literature include short consultation time. It often takes a bit of time to figure out what that person actually needs, how to match the program to their needs. There was lack of awareness of what social prescribing is, and there's inadequate training in social prescribing, and particularly GPs and other health professionals also talked about there being the criteria for prescribing someone to a program are not terribly clear. And there was a perception also among some that social prescribing is not really part of healthcare professionals' role. Patients also identified barriers like lack of awareness of social prescribing programs, additional costs to engage with the program, difficulty accessing social prescribing programs, and the expectation that, well, healthcare is provided by healthcare professionals, isn't it? So there are still those perceptions out there. Okay. In terms of, making social prescribing a reality, in terms of health professionals' perspectives, it was around improving their beliefs about program efficacy, knowledge of patient improvement, following program attendance, and motivational interviewing. So they wanted to know what happens once they refer patients to a social prescribing program. They want feedback. And they felt that that doesn't always happen. Having clear interdisciplinary roles and responsibilities and boundaries. There was talk about remuneration as well. If primary care professionals are going to be doing social prescribing, how are they going to be remunerated? It takes time, and it takes time away from, more medical consultations as well. They felt that recruiting health professional champions who are trained to advocate for the program would be really useful, and programs that can be referred to using multiple options and are ready, accessible, available in a variety of settings and have flexible options would be very useful for them to know about. Similarly, from the patient perspectives, having the availability of sessions and flexibility for both patients and their significant support persons. So we also found that if a partner or the family are involved in the social prescribing activities, people are more likely to engage with them and gain benefit. Improving patient supportive networks, especially during program uptake. So often people don't know what they're being referred to. They are reticent. They don't understand what this is about. And so being supported to actually engage and to realize that this may be of some benefit is actually really important. And managing those expectations and being realistic about what to expect. And again, building the positive and trusting relationships with program facilitators and co-participants. That's through communication and effective program facilitators and peer-to-peer educators. So there needs to be a really good fit with what the person actually needs. And again, multiple referral options were preferred and flexible delivery modes, for instance, by phone or through the web, and not necessarily always having to attend a physical place in order to access a program. They were some of the things that came out. So in terms of effectiveness of social prescribing, well, if you look at the literature, there are pockets of some evidence coming out, but the jury is out, I have to say. There are very few well-designed trials of social prescribing that have been tested and the effectiveness measured. But new evidence is emerging very rapidly. So we really need to be watching this space and learning from what others are doing, including the UK and Canada. And of course, we need to develop capacity and sustainability for these programs. If we are going to introduce them, we don't want to have pilots that then end. They need to be available in the long term to really have an ongoing effect. If you want to read a bit more about social prescribing, the Consumers Health Forum of Australia has some really great information, including a report from a social prescribing roundtable that they held back in 2019 when we could sit in one room together. There's a rapid literature review, which is that probably needs to be updated, but there's some information, interesting information in there as well. And there's the social prescribing roundtable stimulus paper on that website. So please take a look. It's really interesting reading. So where to from here, from our point of view? Well, funding, always. Implementation and evaluation of prescribing models should be allocated in Australia. We believe that social prescribing models, in order to be effective, need to be co-designed alongside relevant stakeholders, so consumers, healthcare providers, and link workers, if that's what we're going to call them. Social prescribing programs should include a link worker. Certainly that's what the evidence is currently showing, that simply signposting people is not as effective as including a link worker. And of course, robust evaluation of social prescribing models. If we're going to be implementing this, we really need to generate the evidence to show that it is effective or it isn't effective and if it's not quite effective, then how can we improve it and change it and make it effective and make it fit? All right, and I think that's all I need to say. So I will stop sharing now. And our next speaker is James Sanderson, and I think Carolyn is going to share his presentation in just one moment. So James is the Director of Personalised Care at NHS England, where he leads on a range of programs that are supporting people to have greater choice and control over their health and well-being. James also became the CEO of the National Academy of Social Prescribing in 2019, where he leads on creating new solutions. So that's a really fantastic program that actually provides education for health professionals, for link workers, and for consumer advocates, which is really wonderful. But I'll hand over now to James.
Hello, everybody. I'm delighted to join your webinar, albeit by recording, to be able to share some of the experiences that we have in England in implementing social prescribing as part of a wider programme of personalised care. So I'm James Sanderson. I'm Director of the Personalised Care Group for NHS England, and I'm also the Chief Executive of the newly formed National Academy for Social Prescribing. So what I want to do is just set out an overview of what we're doing here in England in delivering social prescribing, how that fits into the wider context of healthcare reform, and just my thoughts on some of the work that's needed in order to embed this sort of practice in health economies around the world. So first and foremost, if we look at social prescribing, we look at the state of healthcare today, I think that social prescribing and personalised care represent a new revolution in the way in which we can deliver health and wellbeing support to our populations. If you take the biggest jumps in healthcare over the past 4,000 years, 2,000 years ago in Babylon, they were embracing clean running water and sanitation, which was a major health advancement back then to improve the lives of people. Really, we then jump ahead quite a number of years to the 20th and 19th century, where we started to discover modern medicine. We, in a very short space of time as a civilization, discovered antibiotics. We then went very quickly into advancements in technology, the ability to transplant hearts and lungs, and using tech like MRI scanners and X-ray machines to start to treat people more effectively. Biomedicine also rose during that period of time, and we saw the benefit of drugs and treatments of people, enabling people to survive many diseases and issues. And biomedicine drugs will still play a massive part in how we deliver healthcare support. We're seeing the most significant example of biomedicine impacting on society, obviously at the moment with the rollout of a vaccination for COVID-19. But whilst biomedicine and modern medicine is still effective, we also know that there are limitations in that medical approach. So many of the issues that we're facing now in the healthcare system around the world are societal issues, are issues that people face because of the social determinants of health and because of health inequality that may exist in our society. In England, at least 1 in 5 GP appointments are purely for a non-medical need. People are seeing their GP because they're lonely or socially isolated, because they're in debt, because they have relationship or housing issues to face. And actually over-medicalising the solutions for these individuals is not going to provide them with optimal support. So we're starting to see a need for a new way of approaching people within the healthcare system. And this is why I describe it as a new revolution in health. Many of the things that we face as human beings can be treated with a drug, but actually the majority of things that make us well don't go on inside a GP practice or a hospital. And that's why we've designed a program called Personalised Care in England. Personalised care is about giving people choice and control over the way their care is planned and delivered based on what matters to them, and building on the assets that they bring to their own care. Because whilst clinicians will always be experts in conditions or diseases, people are experts in themselves. We've all lived with ourselves for a long period of time. So personalised care works alongside something that we call the comprehensive model for personalised care. And there are 6 core domains in our model. The first is giving patients choice, ensuring that patients have full choice over the treatment options for them. And we do this through a process within the second part of shared decision making. So shared decision making, many of you I'm sure will be aware, but giving people the knowledge about the risks and benefits of various care and treatment options is really key to them understanding and making the right decisions. And we know that if we apply shared decision making, we can reduce costly, risky treatments by about 20%. We then need to plan effectively. We need everybody to have a personalised care and support plan. We need to look holistically across people's needs. All too often, healthcare systems assume that somebody has cancer on a Wednesday and mental health issues on a Thursday. And of course, our lives are complicated and intertwined at all stages of the day. So we need plans that look across conditions, across diseases. We're then pursuing 3 core delivery programs. The first is personal health budgets, giving people choice and control over the assets that they need to purchase care and support in a way that most matters to them and will support people living with long-term conditions most effectively. And we found that personal health budgets are highly effective, saving money and delivering the outcomes that people need. We're also pushing an approach to self-management support, using health coaching, using structured education, using opportunities to improve the activation that people have in the system. And we know that activated patients, people that have knowledge, that have that control, are able to achieve really, really important outcomes for themselves. And we also know it impacts on the system as well. We have a 19% reduction in GP visits, a 38% reduction in A&E visits, just by people having that level of activation improved. And then finally, social prescribing. Social prescribing is the ability, as everybody will know, to link people to community-based activities. And when we're facing challenges in society that aren't medical, but people are turning up seeking support from those anchor institutions that sit within their communities, from their healthcare system, we know that we need to try and find a different way of supporting people. So we're investing heavily in social prescribing in England. We're putting in a network at the moment of 4,500 link workers across the whole of primary care. So everybody in the country will have access to a link worker. And the link worker's job is to work with that individual in order to support a plan that tailors activities around their specific needs. We've been very successful in recruiting these link workers. We're ahead of target. We planned to have 1,000 in place by March of this year, and we've actually got 1,500 link workers in place. And we've supported over 500,000 people over the past year in delivering social prescribing support. So we're well underway of making this a fully universal service. We're providing significant training and development to link workers. We've got regional support networks in place. And that role is proving to be really important for general practice, with the majority of GPs saying that it's saving them time to care for those patients that have really significant medical needs. Alongside that, the Secretary of State for Health and Social Care wanted to establish an independent body that could champion social prescribing from outside the NHS. And I formed a couple of years ago the National Academy for Social Prescribing. The Academy has a very, very simple remit to increase the noise levels for social prescribing, to championing the work that's going on across the country, to support funding for the voluntary sector, who are at the heart of delivering the activities, so across the voluntary community faith, social enterprise sector, making sure that they've got a vibrant offer, building collaborations across government departments, across sectors of society, working on best practice and building the evidence base for social prescribing. I'm really proud that the Academy's launched a number of initiatives over the past couple of years that are starting to really develop the ecosystem within which social prescribing exists. So firstly, we've got a Thriving Communities programme that brings together organisations working across what I call the 4 zones of social prescribing. So arts and culture organisations, sports, physical activity organisations, organisations supporting the natural environment, and those organisations looking at education, looking at support for people to learn knowledge and skills and find information about the specific issues that they're dealing with. So those 4 zones of social prescribing are coming together in the Thriving Communities programme. We're getting organisations like a walking football club working with a dementia cafe, working with a community choir, working with a lunch club, working with a faith-based organisation in a local community, collaborating to develop a really vibrant package of support for people that are then referred from their link worker in the primary care setting. We've also, through the National Academy, launched a podcast series called Podcast on Prescription that's bringing the messages about social prescribing into people's conscious. And we're promoting social prescribing through a national network of clinical champions and ambassadors as well. Additionally, we've launched last year in partnership with the United Nations Global Sustainability Index Institute, the World Health Innovation Summit, and the World Health Organization, a global social prescribing alliance. And we launched a playbook for social prescribing. And the whole idea here is to embrace the fact that we know social prescribing is a pursuit now on a global scale. Many health economies across the world are looking at the opportunities that social prescribing can bring to deliver health and wellbeing support to their populations. And I'm really grateful for the opportunity to share some of the experiences that we've had here in England, and looking forward to learning more from the work that's going on in countries across the world, and really delighted to see the fantastic progress that you're all making. Thank you very, very much.
That was a great presentation, and as you can hear, there is a lot of activity happening in the United Kingdom around social prescribing. We'll swing around to a more local perspective now to Professor Mark Morgan, who is a GP and a champion of social prescribing. I'm really looking forward to your presentation, Mark. Over to you.
Yvonne, is that the right view, or should I be changing it?
I think that is the right view. Thank you,
Fantastic.
Mark.
That's really good when the IT gods align like that. So I'm a GP. I've been an Australian GP for more than 20 years, both in rural areas and in regional areas, and now in an urban area. And I'm involved in teaching general practice and researching about general practice. So that's my background. But as a GP, I've had a continuous trouble of what to do to best help my patients, particularly people that come where the primary issue appears to be loneliness or isolation. Or I see people with mental illness where behavioural activation would really help, much more than prescribing a pill. Or I see people who need opportunities to be physically active, but that's difficult to arrange for a variety of reasons. I could refer those people to an allied health provider, but that one-on-one allied health provision is really expensive, and there are out-of-pocket expenses. It's not the best solution. I could try prescribing a pill, but I think it's pretty obvious that the pill is not going to fix the problems I've just described. So what's needed is a way to access for those people, to give a number of options and to come to a shared decision or a shared plan to engage in activities that are local, that are affordable or free, and that help to build communities, provide opportunities for volunteerism. And so in my earlier work in this field, the practice nurse became the expert of local environment and what was available in terms of community activities. But it's really hard for somebody who's busy and has many other roles to take on that additional role. And so it worked in a small rural town, but was far, far harder in a larger area. I was also aware that there was this huge gap between, as Yvonne said, signposting an opportunity and that person getting to that opportunity being helped to attend, supported to get there. And then I didn't know what happened after that either. Did they attend? Were there any positive outcomes or not? And I had concerns about sometimes whether it was even safe for a person with a particular physical issues to attend a particular service. How appropriate would it be? So we needed a system. And when I first communicated with the Consumers Health Forum and then with Yvonne, we felt that one way to start this process was to establish a system of gathering information, of reading the literature, understanding what's happening elsewhere and internationally, and then pull people together in Australia in a big round table end of 2019 to start to pull this together. So just to give you a flavour of what social prescribing might look like in Australia, this would be a community house, one of the neighbourhood houses in Victoria, they're called that, or community centres in other states. Men's Shed might be an example of social prescribing, or community garden. But one of the big issues is I might know all about parkrun because I've engaged in it myself, but the GP working in the room next door to me might know much more about the local community choir. So there's a big information void there. So social prescribing roundtable pulled together as many people as we could find to invite and encourage to attend, and really knotted out what this next steps might be to start this process off. And Yvonne summarised some of that, so I won't repeat that. But what happened next was a decision that we had to develop support for social prescribing system at a national level in Australia. And luckily, there are some big things happening that might be supportive of that. So Australia's long-term national health plan contains some key ingredients, and one of those ingredients is the National Preventive Health Strategy. And lucky enough to be one of the members of that organisation, of the steering group of that organisation, so we're able to talk about social prescribing and get some general acceptance of that from that organisation. And the National Preventive Health Strategy is going to be finally released very soon. But there's a recommendation to coordinate and navigate and to link people to services and to the community connections that they need. There's a recommendation in there that link workers should be funded. There's a recommendation in there to formalise and strengthen the relationship between people in their primary care centre, and that should include social prescribing and care partnerships, and helping people to kind of activate and take a greater role in self-care. So that was really positive. Let's hope that something concrete comes from that. Another ingredient of this Australia's long-term national health plan is the Primary Healthcare Reform Steering Group, the 10-year plan for primary healthcare. It's chaired by Steve Hambleton and Waleed Jamal, that you can see on the screen. And these are two excellent GPs with a lot of experience, and they have been tasked to chair a steering group with representation, including the Consumers Health Forum, the RACGP, and many other organisations thinking about primary care. And that also, the report from that also contains a push for supporting the sort of models that we're talking about today. So that's two arms coming together, both from preventative health and from primary care, that will, I think, add some political weight to this. The third thing that's happened is a group called the Australian Health Policy Collaboration out of Victoria University, and they produced a self-care policy blueprint. And that was sort of launched with a big fanfare, with Greg Hunt not only launching it, but endorsing its content and saying, yep, we'll add that to the agenda of the two committees I've spoken to before, and try and get it into the budget for for 2021. So we're hearing positive things, and I think that's good news. The Self-Care Policy Blueprint talked about supporting the volunteer sector to work collaboratively with health sector. So the question is, what are the next steps? We're seeing examples of social prescribing in Australia, but they're a bit ad hoc. So there's some great work coming out of neighbourhood houses. Some of it's funded with federal funds. Some of the PHNs, the primary healthcare networks, there's 31 across the country. Some of them are really buying into this, particularly to support serious mental illness, which is one of their kind of key areas to commission services. We're seeing many GPs anecdotally tapping into local opportunities to connect people to services that are available locally. But what we're not seeing yet is a commitment to fund link workers. We're not yet seeing a system that really pulls together all the information held in local government, all the information held at PHN level, all the information held in people's minds, and to make it available and accessible across the board. So I think I will leave it there. Thank you.
Thank you, Mark. That was fantastic. I think the will is there. We just need to make it happen. And the foundations are being laid in terms of policy development and so on. But yeah, we have a ways to go, and we have friends in the UK from whom to learn, and others. All right, thank you so much, Mark. I'll now hand over to Carolyn Dew. Carolyn has actually run and developed a social prescribing program, so really looking forward to hearing about your program, Carolyn. Over to you.
Thank you. So my name's Carolyn Dew, obviously, and I'm an artist, and I've worked in the arts industry for a long time, and in many different roles in education, in galleries, in community cultural development, and each of those different parts of the arts industry really all encourage increased participation in the arts. So, and all of them kind of acknowledge the benefits that participation in the arts have on your health. So I just want to talk to you about the Cultural Pharmacy, which is a project, kind of has 2 tiers of development. The original Cultural Pharmacy was a sort of short-term multi-arts installation, so it was up for several days. It was produced for a conference, and within that there were general tonics and location-specific tonics developed. And then the second level, which tried to really hone down that project and take aspects of that project and develop a more sustainable model that would fit more, I suppose, more neatly into that social prescribing formula. So this is the first version of the Cultural Pharmacy. So it was an installation. You walked, it was set in the conservatory in Bendigo, which is a beautiful sort of Victorian building. So you had to walk through a park to get to it. So in a sense, your experience started as you went through nature and walked through the park. In the conservatory, there were plants, the gardeners from the Bendigo Council, which is where the project took place, they grew all these herbs for us. So you walked in and there was a sensory aspect of the smell as well. And then people were taken into a kind of performative and participatory kind of experience. So you can see in the first photograph, people were invited to make paper flowers. And those flowers were, as part of a kind of ritual performance, were put into this theatrical distilling sculpture. And out the other end would come the prescriptions. And as you went, you'd enter one end of the conservatory, and as you left through the other end of the conservatory, you would be given what we called a cultural tonic. And those tonics in part were really to introduce people to the assets of the area. There were a lot of visitors in town for the conference, so it was kind of connecting them to what was going on. And for other people, they might be kind of really general tonics, for instance, tips on how to dance every day. The next version was a testing project. So this was kind of really just distilling it down to the prescribing. And we had lots of ideas in mind for that we were going to test, which included potentially having a small sort of cultural pharmacy in a GP service or in a health service. But COVID came, and really that changed a lot of what we could test. But basically what that was supported by the local council, Mount Alexander Shire, which is Castlemaine, Malden, Central Victorian area. There were already key health objectives, which included increasing physical activity and improving mental health. So we used those to focus on what we would be prescribing tonics for. And then we would put together prescriptions that pulled from the local cultural assets of the area. And that might be, you know, national parks, artists, dance courses, the community house. There's just a rich array of things available to people within that area that they could be linked to help them improve their health. So this is just a basis of the information that we used to target what health measures we were going to try and improve. And it's incredible that on the third line that GPs in the area prepare mental health plans for almost 50% of their patients. So that, you know, is reinforced by what the other speakers have also said. And so we thought, you know, we're looking at a strengths-based approach here. So while there are these issues of poor mental health and a lower than average life satisfaction, the area also has a really strong creative industry sector. And so that's kind of perfect combination for what we were aiming to do. So some of the testing that we were able to do was with the healthy ageing team within the council. So while our program wasn't necessarily going to be targeted specifically to a certain age group, at the start of the pandemic, that was seen as a particularly vulnerable group of people. And we were just able to work with them to deliver a number of different things. So here is an example of some kind of general cultural tonics that we were able to deliver through a newsletter that they would get out to all their elderly residents within their network. And then we also did a kind of one-on-one prescribing to a smaller group of people. So that smaller group of people, it was important to find out what their interests were, to find, you know, were they interested in music, drawing, what had they done before, what were their kind of physical barriers to be able to do things, and then to kind of find a prescription that would really suit them. So as part of the testing program, we developed these new prescriptions, and the idea, or tonics, I should call them. And the idea is that in part the categories helped you to target, you know, what you're addressing for each individual person, but there's also something intrinsic in the object, you know, someone is given this object within the tonic, there is an activity that they can undertake that's specific kind of for them. And within the tonic that you're giving people, it's also really important, I thought it was important to give people the information on why undertaking that particular activity was going to be of benefit to them. And you'll see there are different ways in which that's described, like, you know, the benefits of connecting, contemplating, creating and moving. So this is an example of a cultural tonic. To the left, we'll have, you know, information about what this particular activity does for you that has a positive health benefit. And these are all drawn from sort of proven benefits, I guess. And this is an example of a kind of layered tonic. So start with the beneficial ingredients are given. You're given a kind of prescribed activity. So there's something very literal, and you can go and do this particular thing. And then just instructions, you know, how you get there, what's available. And then other sort of options for people. So it might be that you're giving someone something a little to the side, you know, that they mightn't want to particularly go to those gardens, but if they want to, they can look up a guide of walking in the Shire, and they might find something closer to them. Then there might be online links that people can also look up, or just additional information. So each of the tonics kind of has different entry points, and allows people to find a bit more scope to find the thing for them, and also to show people that yes, this is one activity, but it kind of connects into other things that people are doing. You know, there might have been other tonics, for instance, that might have sent you the Castlemaine Botanic Gardens, but then it would tell you how to join the Friends of the Gardens, or, you know, other ways of entering into what's going on in your community. And also, I guess when we talk about cultural assets, also one of the things that we felt was important was, you know, that you can have a fresh look around where you live, and that there might be places to go or things around that you have never fully discovered, or that you can go and revisit and experience them in a different way. So we did these tests, and we were really hoping to go to a stage 2 of this project. Unfortunately, a lot of that funding sort of just went off to COVID, and we were unable to do that. But what was great about doing the testing project was we did develop really strong links to services, the health services within the Mount Alexander Shire Council, and we worked out by kind of co-designing with those services, we worked out that a 2-tier kind of delivery mode was possibly a good way to go. And that's, I guess, back to what people are talking about, of how much people are linked, how much support they get to assist them to attend or try different things. And we just saw that there could be 2 tiers. One where you get a tonic and the information is given there within the tonic, and the other is a more kind of individual service where, you know, you might be given a warm introduction to a dance class or the community centre. Someone might go with you in the first instance, or the person at the community neighbourhood house would know that you're coming and welcome you. We also looked at things like being able to offer discounts if you came with a tonic, you know, and joined up to a class. The cultural tonic kits, we thought, for the GPs, just a kind of really a more efficient way to be able to get GPs to hand people something on the day, and to be able to do it quite quickly, and for it to not eat into their time quite as much. And that, of course, would have required, you know, we would have worked with them on helping them to use the cultural tonic kit. I think the next, and also we developed an evaluation plan that was with Dr. Michael Leach from Monash University, really generously put together an evaluation plan for us. So we've sort of got this project that's ready to go to the next stage, but like we're all discussing, you know, resources are the thing. There's plenty of interest in the community. There are a group of people now working together to see how they can get a broader kind of social prescribing project going. You know, ours is quite arts and cultural focused. So yeah, it's promising, but resources are the major issue, I guess. Okay, thanks.
Thank you so much, Carol, and it's fantastic to hear of your experience. And I guess things are on hold because of COVID, as many things are at the moment, but hopefully you can get restarted once you're out of lockdown and this is over or normalised.
Yeah.
Thank you so much. We'll move to Helen now. Helen is a consumer advocate, and she has personal experience of actually engaging with social prescribing programs. So over to you, Helen. Thank you.
Thank you, Yvonne. Yeah, my name's Helen Longhurst, and I'd just firstly like to say thank you for inviting me to join the webinar, and I'll just share with you today how I come about to know about social prescribing. Basically, about 2.5 years ago, I had a flare-up with my fibromyalgia, and I was just in a lot of pain and basically laid up on my couch taking pain medication and heat packs all over me to try to manage my pain, and consequently it went on for several months, of which then I developed depression and anxiety. And yeah, I had an appointment with my GP, and he suggested basically to try some physiotherapy. So he gave me a name of a physiotherapist, and when I got home that day, I rang to make my appointment, and I found that that physiotherapist no longer worked at that clinic. So I just went to Google, and I just Googled physiotherapists near me, and so I searched a few of them, but then I came across the IPC Health website, and anyway, I clicked onto their website, and that's when I come across under their services section, social prescribing, and I thought, the curiosity got to me, and I thought, well, I'll just find out a little bit more about it. So I just read a little bit about it on their website, and I decided to call and speak to the facilitator, and I did that straight away basically, and she was a lovely lady, who listened to me and suggested for me to come and see her and just have some time to talk things through with her. And so I did that, and yeah, I had a couple of interviews actually with her, and she referred me firstly to a support group, a chronic pain support group, which I was unaware that I had one so close by to me. And I went to a few of those sessions, and I started to feel a little bit better mentally, that, you know, being around other people and just sharing our experience of how we handle the pain, and just, you know, having people believe that you're feeling pain, because it's something that people cannot physically see. It's something that you experience personally. So that meant a lot to me, that, you know, these other people understood how I was feeling. And yeah, later on, Catherine, the facilitator at IPC Health, she contacted me and referred me to another program at Westvale Community Centre. It was a gardening and cooking program, and they're two things that I really, really love to do. So it was ideal for me, because it also helped me with my depression, and it just helped me not to feel so alone and isolated like I was at home. And yeah, basically, you know, it's been great. I'm still involved in the program. Actually, that one has finished, but there are other programs that are available there, and so I'm participating in them now. And yeah, can't wait to get back to it once the lockdown's over. So yeah, I think it's a great idea. I always believe that, you know, the mind and body and the well-being of the body as a whole plays a big part in, you know, how we feel, and how it just helps us to recuperate, you know, mentally and then physically. You know, I saw a great improvement in my pain, and I think I put that down to, instead of being home alone with my pain, where that's all I focused on, I was out amongst other people, out in the garden, in the kitchen, cooking beautiful things, and you know, sharing them together was great. So yeah, it's a great service, and I want to tell everyone about it. Thank you.
Thank you so much, Helen. And you have told many people about it now, which is fantastic. Thank you so much for sharing your story. I think it really illustrates the benefits of social prescribing. And we've had a bit of a journey today from, you know, the more academic, you know, what does the literature say, to what's happening overseas, to what's happening in Australia in terms of policy and practice, you know, and a fantastic example of an actual program that Carolyn developed, and then your story to show, you know, the end result. This is why we want social prescribing to be more widely adopted, because there are potentially huge benefits. All right, if I could ask our panel to please come on camera and unmute yourselves. We might take some questions and have a bit of a discussion. Please put your questions into the Q&A box and we will endeavour to answer them for you. Here's a question from Maya or Naja, I hope I'm pronouncing that right. And she's interested in understanding what supports are needed for community organisations to effectively participate in social prescribing. And is there any evidence about that? I guess that goes to you, Carolyn. So you've actually done this in the community. What did you need to make it happen?
Well, I guess for me, and just being conscious that we really focused on more the cultural prescribing aspect, but well, I think just, you know, it's almost like everything is there largely, and it really is just about making those links and also just having that expertise to translate what those particular community organisations or services, how they can actually assist people in their health and how they can actually influence the social determinants of health. So it's just that knowledge, I guess, and then it's really just the resources. It's actually not a lot of resources, I don't think. You know, for us to run our program, and it would have been, yeah, a lot of work, particularly getting everything established, but really it was two people part-time, you know, or two, not even the equivalent of one full-time person. But of course, each of your partners has to make a commitment too, and that commitment can vary. So each of your partners has to have capacity as well. You know, GPs have to be committed and have the capacity, but otherwise to actually, implement it, it's not a lot, I don't think.
Yeah, thanks, Carolyn. It's interesting you mentioned GPs and GP capacity. Mark, would you like to comment on that? What do GPs need to implement social prescribing?
I think the GPs need to firstly have some awareness or way to access the range of things that are available. Now, ideally, that would be through a link worker in-house, so that there's a kind of an education and two-way conversation with GPs. But even in the absence of formal link workers, just knowing your local environment, being open to what the resources that gather opportunities. Many local governments produce fantastic kind of updated quarterly lists of what's available out there. And I think that's the sort of information the GP, and particularly the practice nurses that are often writing the care plans and spending time coming up with a personalised management plan with people, should know about and have access to. But I also, listening closely to that, the amount of resources for the providers, if you like, the volunteer organisations or community groups, are not huge, but there are some basics that would be lovely if you know, indemnity insurance was just universally adopted as a kind of taxpayer-funded activity. It'd be useful if there was a kind of up-to-date contact details, a list of who might benefit, and you know, almost a structured form for what does my service do? Has it got capacity? Is there a waiting list? What languages are spoken in the service? And that sort of information would make it much easier to direct the person in the right direction.
Yeah, I might just ask Helen, because Helen, you kind of stumbled across social prescribing. You kind of found it yourself. You mentioned the IPC website. Tell us about that and how you found it.
Yeah, I first looked at the physiotherapists, of course, that were available there, and then I just had a look to see what other services they provided.
Nice.
And that's where I noticed social prescribing, and I'd never heard of it. And like I said, I was just curious as to what it was, because never heard the term before, or you know, and I just wanted to see what it was all about. And after reading just the brief description on their website as to what it was, so I just thought I'd ring to find out more and see if I was eligible to access the service actually. I didn't know if there was a criteria that I had to meet. But yeah, it was open to anyone.
Yeah. And so when you went back to the GP and told them what you had accessed, what was the reaction?
Well, he was really pleased, and he saw the change in me. You know, I was much more positive, and I just had a lot of ideas and things that I wanted to take up again, you know, hobbies and things that, you know, I just didn't do. But he didn't know anything about social prescribing. I think this is the big thing that a lot of GPs don't know about it, and a lot of patients, a lot of people that are not feeling well physically or mentally, and they don't know about it or where to go to find it.
Yeah. I might just go back to Mark. Mark, what's your response to that? I mean, is it the terminology? Are we using strange terminology that's not familiar to GPs?
I mean, we certainly are, because it's not really social and it's not really prescribing. So we are using strange, but you have to use terminology to pull something together, and to have a term that you can refer to. But I think the non-formal prescribing to another clinician and non-pharmacological approach to managing problems is something that needs more promotion amongst my colleagues, because I think increasingly the system will implode if we rely on formal referral processes and the vastly inflated costs that can generate. I'm really interested in Helen's description of the relationship. I think it was with Catherine, the person that was kind of doing the warm handoff and making the suggestions. You know, that was the link worker role in person. You know, and how important that seemed to be in the way that Helen, you found your opportunities to be involved.
So staying on the idea of actually funding social prescribing, there's a question here from Lauren Perry from IPC Health. Hi, Lauren. She's saying, is there work happening in the item number space so GPs can receive support for their involvement? So this is looking at MBS items, so you can be reimbursed for the work. Do you know anything about that, Mark?
Yeah, look, item numbers are quite a blunt instrument, because they tend to generate churn or repeated activities, but not necessarily high value activities to the people that are most in need. So the work's actually been looking at alternatives, which is to link block funding for services provided by a practice, and people can voluntarily enroll with that practice. And the kind of flip side of voluntary enrolling, you know, you're accessing a lot of extra services, but the practice receives some funding that might pay for care coordination activities, social prescribing activities, and a bunch of other things. So I think it's looking at providing the infrastructure in a funded way, rather than a fee-for-service item number that just generates activity.
Yeah, okay, thank you for that. There's another question here from Kerry about cultural tonics, Carolyn. They're a wonderful way of connecting people to their local communities. It would be terrific means for relating to other cultures, such as First Nations, you know, storytelling, as well as those from culturally and linguistically diverse communities. that included food, customs, etc. What are your views on developing more sort of culturally appropriate services?
Yeah, look, I think it is really important, and you know, it is as important to, if you've got an Indigenous person looking to make connections, you know, it's important to steer them towards their community and also towards them finding out and participating in culture that is relevant to them. But it is also, of course, as the arts is a great conduit for cross-cultural exchange. So I think the thing we would have considered within our topics is to give people kind of as much opportunity and choice for those sorts of different interactions as possible. And I guess to be aware of what might limit or assist accessibility. So this is a slightly different example, but one of the great things we learned in the testing project was, you know, I'd be using in my tonics a kind of arts language, and the health workers would come, or the people, you know, our partners would come back and say, look, you know, some of these people have got different cognitive issues, or, you know, can you just cut the language back and consider that? So things like that were just fantastic to remind you that you've really got to have a broad appeal, and you've really got to make what you're offering accessible. And, you know, language and kind of cultural diversity, that's all part of that, I think.
Yeah, thanks, Carolyn. I think all the speakers throughout this webinar have talked about, you know, being patient-centred and meeting that personal need. And so we really do need to take account of the contexts from which people come and look at their individual needs. There's a really great question here, which I think is for me, and maybe for Mark. What kind of data are currently used to provide evidence proving that social and cultural prescribing is effective, measuring health outcomes or health quality? Is this evidence typically collected quantitatively with surveys, or qualitatively with focus groups, etc.? This is from Leanne. She says she's a curious speech pathologist. I'll take the first bit, and then maybe Mark, you can add to it. So Leanne, thanks. That's a great question. And as I alluded in my talk, I don't think the evidence is terribly watertight. However, much of the evidence around social prescribing may not be in peer-reviewed literature. We may find a lot more in grey literature, so in reports that don't appear in journals. But the field is moving, and it's moving rapidly, and people are doing robust evaluations, and they are measuring quality of life before and after, you know, in pre-post designs. There are very few trials, controlled trials going on that I know of. But yes, people are starting to measure, and particularly among the older age groups, we've seen lots of papers around measuring cognitive benefits using standardized instruments, etc. So things are moving, but I think by no means do we have that answer for you. I think there's a lot more work to be done. And Australia has a real opportunity to actually design really robust evaluations and trial and pilot systems of social prescribing to generate that evidence. Mark, do you want to add to that?
Yeah, well, when somebody talks about outcomes in healthcare, I think of outcomes as not just clinical outcomes, but there's the experience of receiving care, and then there's the patient-reported outcomes, so quality of life, for example, and the experience of delivering care. And then there's an economic outcomes as well. Is this care achieving the same result, but a lower cost than the alternative. So it's quite broad. And I think we tend to focus on clinical measurement, does blood pressure reduce, rather than equally important, actually receiving this care is far more attuned to the way I want to receive care, and being able to deliver care in this way works in a sustainable way for me as a GP. Those are much more valuable measures of outcome than comparing a pill for blood pressure and social prescribing for blood pressure.
Yeah, thanks, Mark. Okay, Thomas Astelbert is saying, could the panel recommend a published case study example of a randomized trial to determine the effectiveness of a social prescription that I might use in my teaching? We could certainly look for some. I think there were some in the rapid literature review that we did for the Consumers Health Forum. And I've got several students working on their MD projects around social prescribing. So there will be some. Thomas, if you would like to drop us an email, we will send you some stuff.
The other place to search would be the Australian Disease Management Association that has a social prescribing tab. And in that are collected resources, including Yvonne's literature review and the report from the RACGP and Consumers Health Forum roundtable, and then a bunch of other things. So that's a nice place to go looking, the Australian Disease Management Association's website.
Thanks, Mark. That's a really good resource. Okay, there's a question from Hayley. Are social prescribing and link workers the preferred, most commonly used terms? Here we are, the terminology raises its ugly head again. Anyone from the panel want to take that?
If you're talking academic discussion and funding programs within, when you're talking to the Department of Health, then those are the words you use because they've got definitions and they mean something. But I think when you're talking to people in the community or to health workers that are at the coalface and working, then I think you have to explain what you mean by those things because they're often doing it without knowing that it's called that.
Carolyn, what did your clients call you or your staff?
We really called ourselves cultural prescribers, cultural pharmacists, very loose use of the term, really. Yeah,
okay. But I think Mark's right. We do have to have some standardised terminology in order to influence policy. Policymakers need to know what we're talking about and need to understand what we're talking about.
Agreed.
Okay. We're almost out of time. Ben says, is there a website that GPs can refer patients to that is a database for community services? I think Mark mentioned that just now, so I think we've covered that off. I'm just looking through the questions. Rod McIntosh is saying we're conducting social prescribing program in the Frankston Mornington Peninsula area in Victoria. Currently undertaking an evaluation program. Fantastic. And there's a link in the chat there if people want to have a look at that. So things are definitely happening, but as Mark said, it would be really nice to have a cohesive approach to this nationally. Any final words from our panel? We're just about out of time. All right, then I just want to thank you so much for coming on today and sharing your stories and your thoughts about social prescribing. I think we have a long way to go, but we have a really great basis from which to start. And I certainly look forward to future developments in social prescribing in Australia. Thank you very much, everyone.
Thank you. Thanks to everyone else.